Thank you for joining me today. I'm Carol Florman, a policy fellow with Cancer Care. This is the second of a two-part series about health insurance coverage and ways that insurance company policies may limit your access to care. Utilization management, which is also known as is an umbrella term for rules that insurance companies and pharmacy benefit managers use to control access to certain types of treatments and prescription drugs. Their job is to reduce costs by determining whether healthcare services are medically necessary and appropriate for patients before the patient can receive them. Can help to prevent unproven or unnecessary treatments and reduce costs while still allowing patients to receive quality care. Unfortunately, can also delay or deny necessary care, create extra work for doctors and their staffs, and frustrate or even cause harm to the patients trying to access needed treatments. Today, I will walk you through several common techniques that your insurance company may use to control access to healthcare services. You'll hear me talk about insurance companies and PBMs. Your insurance company manages your medical benefits, and your PBM, which is a pharmacy benefit manager, manages your prescription drug benefits. I'll be talking mostly about prescription drug benefits in this presentation, but remember that the insurance company and PBMs are partners and very often part of the same company. During the presentation, I'll discuss each of the practices in greater detail. I'll describe what the practice is, why insurance companies insist that they need to use it, what problems may occur because of the practice, and anything else that patients need to know about how it may interfere with their access to care. Pre-authorization, which is also known as prior authorization or PA, is when an insurance company or a PBM requires that a doctor obtain their approval to prescribe a certain prescription drug or a treatment before they'll agree to cover the cost. When a prescription requires PA, the doctor's office submits information to the PBM about the patient's condition and their treatment plan. The patient cannot fill their prescription or receive a treatment using their insurance until the PBM approves the prescription. Insurance companies and PBMs say that PA saves money by ensuring that a prescribed medication is medically necessary and that it protects patient safety by having them check whether the prescription is right for the patient. Now, before I go to the next slide, I'm going to point out the case study pictured on the right side of the slide. Amy is a real patient who's experienced problems with her cancer treatment due to prior authorization. If you have a smartphone, you can point your smartphone camera at the QR code below her photo, and that'll take you to a short video about PA and hear Amy tell her story. The video can also be accessed on the Cancer Care website at www.betterrxbenefits.org. There are similar case studies included on coming slides that describe how other practices can impact patients. The videos can also be viewed on Cancer Care's website. Doctors and patients report that prior authorization often results in delays. Doctors' offices sometimes hire extra staff just to process prior authorization requests, which of course adds to the overall cost of healthcare. Sometimes PA can be done instantly through an electronic system that provides an immediate approval or request for additional information. Unfortunately, however, PA often requires the doctor's office to fax in a PA request and then wait for the request to be processed. This may take days or even weeks, during which time the patient cannot fill their prescription or begin their treatment. For a cancer patient, a delay in getting needed medication can be risky and stressful because these medications are necessary to control their cancer or side effects from treatment. If the PBM does not approve use of the drug, the patient has several choices. They can ask their doctor to prescribe a different drug than the one that was first prescribed. They can pay out of pocket for the full cost of the medicine, or look for discounted ways to get it, or they can appeal the insurance company's decision. I'll discuss appeals later in this presentation. It's important to know that when prior authorization is granted, it is usually for a specific length of time or a course of treatment. Patients and their clinicians must ask for this authorization again if a refill is needed. Now, as I described in the first webinar, every insurance plan has a drug formulary, which is the list of drugs that a health plan covers. The formulary is created by your PBM and can change over time. Sometimes PBMs change their formularies in the middle of a plan year. When that happens, the PBM will tell patients if the prescription drug they are taking is no longer going to be covered and let them know which drug or drugs they may be able to take instead. This is called non-medical switching, which means that the PBM is asking a patient to switch drug for a reason that is not related to their treatment plan. Non-medical switching usually happens because a PBM has removed a drug from its formulary, or it's moved it to a higher, more expensive tier. Now, it may be because there's now a generic for that drug, and they want patients to take the generic drug instead of the name brand. That type of switch is usually not a problem for patients. But PBMs often change the drugs on their formularies because they've negotiated a better price or a bigger rebate for a different drug than the one that has been on the formulary. Now, that type of switch from one drug to another can sometimes have negative consequences for patients. Cancer treatments are becoming much more targeted and personalized, with different people needing different drugs due to the complexities of their disease and their genetic profiles. People can react differently to different drugs. One person may have significant side effects from a drug, while another person can tolerate it easily. When a PBM makes a patient change their prescribed drug to a different one, it may cause a variety of problems. The new drug might not work as well, or it may cause side effects. The drug may be more difficult to take, such as switching from a twice-a-day pill to a powder that needs to be mixed into liquid and taken several times a day. And when someone finds a drug that is too hard to take or makes them feel sicker, they may stop taking it, which could allow their disease to advance. And sometimes, when a patient is switched from a drug that is working well to another drug, it may not be safe or effective to switch them back to their original drug, even if the other one fails. When insurance companies and PBMs force patients to switch drugs for non-medical reasons, they are overruling the treating doctor's opinion about what is best for their patient. If your PBM asks you to switch treatments, talk to your doctor. If it's a simple change to a generic drug or one that is very similar, the switch may not be a problem. But if your doctor disagrees with the PBM's change, ask them to help you appeal the decision. If that doesn't work, explore whether there are other ways to get your prescribed drug. Your doctor or pharmacist may have suggestions on how to get the medication without using your insurance. Financial assistance may be available through discount cards, drug company patient assistance programs, or other patient support programs. And then, during the next insurance open season, see if another health plan available to you covers your medication. Now, step therapy is used by PBMs to lower its costs. It requires that a patient try one or more cheaper drugs before stepping up to a more expensive drug prescribed by their clinician. Insurance companies and PBMs say that step therapy encourages the use of the most cost-effective drugs, but what saves them money might come as a cost in health, comfort, or convenience for a patient. Usually, the patient will have to use the PBM's chosen drug for 30 days or longer. If, after the trial period, the required drug isn't working or is causing problems, the doctor can fill out an exception form that asks the insurance to cover the more expensive drug. This often results in successful coverage, but if the PBM denies the request, the patient may need to try yet another drug chosen by the PBM or pay the full price of the more expensive medication out of pocket. Next slide, please. When PBMs require step therapy, they are putting cost ahead of patients. They may not want to cover a new, expensive cancer drug and instead require patients to use older, potentially less effective drugs. This can create problems for patients because when cancer patients don't get the right drug at the right time, their cancer may spread and patients may get sicker. It can even lead to complications that require increased medical care or hospital visits. Some PBMs require step therapy even if a patient has tried a drug in the past and it has failed. Several states have passed laws that limit the use of step therapy and provide protections for patients. But unless you get your insurance from the ACA marketplace or have another plan regulated by one of those states, you may be subject to unregulated step therapy. If you find yourself in a position where you are required to follow step therapy against your doctor's wishes, ask your doctor to help you appeal the decision. Many appeals are successful, and we'll talk about those later. Justin Williams was a healthy 28-year-old when he was suddenly stricken by polymyositis, an inflammatory disease that causes severe muscle weakness. In this short video, Justin explains what happened when his insurance company forced him to follow step therapy before receiving the treatment he needed.
When I was 28 years old, I'm doing my morning routine. I walked into the bathroom, ready to brush my teeth, and I just dropped to the floor. I passed out. And I went to my primary care physician, and he noticed a high increase in the CK levels in my blood. He referred me to a rheumatologist, and the rheumatologist knew right off the bat that I had polymyositis. He knew the drug rituximab would be my silver bullet, but he knew that from previous patients that he would have to take me through the process of step therapy. As part of the step therapy process, my doctor prescribed high doses of prednisone. He prescribed other drugs to help with the prednisone so that, my organs didn't have any organ failure. About 8 pills a day. Taking all that medication daily, I would be tired. I couldn't focus on things, blurred vision. My fingers would get numb and turn white. I've developed rashes, bad acne. I was constantly irritable. For someone going through a chronic disease, you're already in a hell. And when you add step therapy on top of that disease, it just puts you further in. And it's almost a slap in the face to someone who's paying for insurance. It's almost as if they see you as just a number on, a sheet of paper.
Under most insurance plans, the insured person must pay a specified amount for covered drugs and services before their insurance company starts to pay a portion of those costs. This amount is called the patient's deductible. Once they've paid the deductible in full, the insurance starts paying a portion of covered care, and the patient pays a copayment or copay, which is a set amount, or coinsurance, which is a percentage of the drug costs. Now, health plans also have an out-of-pocket maximum, which is the most a patient must pay for covered drugs and services in a plan year. After a patient has paid this amount, the insurance company pays 100% of the costs for covered in-network benefits. Now, patients who need expensive drugs sometimes get financial assistance to help them pay for their share of the medication costs. This assistance may be in the form of a coupon from a drug company, or funds from a copay foundation, or from another charity. The financial assistance, which is often referred to as copay assistance, is paid to the insurance company on behalf of the patient. And until recently, it was treated no differently than as if the payment had come from the patient's own pocket. This means that the financial assistance payments counted toward the patient's annual deductible and out-of-pocket cap. Many insurance companies are now taking advantage of the financial assistance, which is meant to help patients, by putting in place copay accumulator rules, and these are often referred to as copay accumulator adjustment programs. These programs exclude third-party copayments from counting towards those deductibles or out-of-pocket caps. This means that patients, no matter how many thousands of dollars have been paid on their own behalf, must pay the deductible and out-of-pocket cap a second time from their own funds, something that many patients cannot afford. Next. Now, this chart shows how a patient's out-of-pocket costs and payments received by PBMs change with and without a copay accumulator program. In the top chart, you'll see how the financial assistant paid on a patient's behalf is counted towards the patient's deductible and out-of-pocket maximum. By the time the copay assistance runs out, and it always does run out, the patient's deductible is paid in full, meaning that they're only responsible for their copay or coinsurance until their out-of-pocket maximum is met. In this example, over the course of the year, the patient pays a total of $2,000 from their own funds. The copay assistance charity pays $10,000, and the insurer pays $12,000. The bottom chart shows the impact of a copay accumulator program. When the copay assistance runs out, the same patient must pay $6,000 out of pocket, including payments of $2,000 and then $1,500 during the 2 months between the assistance ending and their meeting their deductible. The copay assistance charity pays the same $10,000 that it did in the previous example, but the insurance company now only pays $8,000, shifting that other $4,000 to the patient. Copay accumulator programs have become very common, but they aren't always easy to notice in insurance plan documents. Make sure you read your health plan's documents and look for terms such as out-of-pocket protection program. That's what Express Scripts calls it. True accumulation. Caremark, CVS calls it that. Coupon adjustment benefit plan protection program. That's United Healthcare's term. The documents may also just state that they do not count payments from third parties or drug company discount cards toward your deductible or out-of-pocket maximum. Some states are now requiring that health plans that they regulate to count any payment made on behalf of a patient toward their deductible and out-of-pocket maximum. Unfortunately, these state laws don't apply to large employer-based plans or employer self-funded plans. Now, some insurance plans have implemented a similar program called a copay maximizer program, and it's very much like a copay accumulator program, except they'll spread the financial assistance out over the course of the year. This might make it a little easier for a patient to afford their medications, but these programs also exclude the financial assistance received by the patient from counting toward their deductible or out-of-pocket maximum. Now, be aware that additional names may be used for copay maximizer programs. When an insurance company or a PBM denies coverage for a treatment, requires a step therapy protocol that might be harmful, or excludes a needed prescription drug from coverage, you can appeal their decision or ask for an exception. It's estimated that fewer than 2% of patients whose coverage is denied appeal their decision, but a large percentage of those who actually do appeal win. If your coverage is denied, it's usually worth appealing because there's another drug unless there's another drug that your doctor thinks will work as well for you and that would not cause side effects. Appeals for prior authorization denials are usually decided in the patient's favor. Exceptions to formulary exclusions or step therapy protocols may be harder to win, but still worth pursuing. Patients should work with their doctor's offices to provide the requested information to the insurance company or PBM about why the prescription drug is the correct treatment. Sometimes the doctor may have a phone conversation with another doctor who works for the insurance company. This is called a peer-to-peer review. Don't let the denial of a needed treatment go unchallenged. Be persistent and work with your care team to make sure that the insurance company or PBM gets all the requested information in a timely manner. It can be hard to advocate for yourself, but when insurance companies and PBMs wrongly deny needed treatments, patients should stand up and fight for their rights. We hope that the information provided in this webinar has been helpful. For more information about utilization management, please check out our resources on the Cancer Care website or visit www.betterrxbenefits.org. Thank you for joining me.